Thank you for that introduction. Hi, everyone. My name is Ken Lim. I'm a doctoral candidate at the Boston University School of Public Health, and I study health services research. Just want to take a moment to thank my co-authors listed here, who played a big role in the project as well. So for some context, food insecurity is an important concern for the Medicaid population. Nearly a quarter of beneficiaries reported not having enough to eat during the start of COVID-19. And many of you know having unmet basic needs is associated with adverse diabetes-related clinical outcomes and poor access to care and quality of care. Individuals with food insecurity are significantly more likely to have frequent ED utilization than individuals who are food secure. So finding ways to address food insecurity not only has impacts on patient health, but the healthcare system as a whole. So one way to address this is through the use of food pantries. So food pantries have been shown to improve patient access to healthy foods, stabilize blood glucose levels, help patients maintain healthy weight. However, despite extensive research on this, food pantries are pretty underutilized. For a number of reasons, patients might be uncertain about the location of these food pantries or whether they qualify. One study showed that 67% of food insecure households didn't actually use them, despite being eligible. So finding ways to improve access to food pantries might be one way to mitigate the impact of food insecurity on poor health outcomes for these patients. So that takes us to our study setting, Boston Medical Center. As many of you know, BMC provides healthcare for predominantly low-income and under-resourced communities, and it's the largest safety net hospital in New England and one of the biggest in the country. In 2001, BMC opened the first hospital-based food pantry in the US to address nutrition-related illness and underutilization for low-income patients. And you can see in that picture, that's actually the food pantry at BMC. So this is kind of like a logic model of how the process works. So first, patients are seen by a primary care doc or in the emergency department. All patients at BMC are systematically screened for health-related social needs. And if patients indicate that they're experiencing food insecurity and would like assistance, the PCP can refer them to the on-site food pantry with a healthy food prescription. And here, patients can visit the food pantry every 2 weeks, receive 3 to 4 days worth of food. And the innovation here is that patients can receive fresh produce and proteins and foods that might not be available in a community food pantry setting. And this significantly reduces patient burden. So despite the evidence that suggests food pantry use improves health outcomes, there's few studies that explore how they impact healthcare utilization. And so our paper helps to fill this evidence gap by looking at this question using pretty innovative causal inference methods and a unique set of panel data from BMC. So our data source was the BMC Clinical Data Warehouse, which has robust data on patient characteristics, healthcare utilization, clinical indicators for diabetes and blood pressure, as well as visits to the BMC food pantry. Our data was organized at the patient quarter level from July 2015 to December 2019, and note that long time span is really important to see kind of the longitudinal effects of food pantry use. Our inclusion criteria was individuals enrolled in Medicaid, aged 18 or older, those who received primary care services within the BMC system, those who were at risk of or had diabetes, and those who visited the on-site food pantry at least one time during the study period. So everyone in our study went to the food pantry, and that's important to note. So our analytic design was a staggered difference in differences approach, which builds off the traditional difference in differences approach that assesses the impact of a policy or an intervention. But the interesting part here is that individuals utilize the food pantry at a lot of different times. So using kind of a standard diff and diff is not possible. And we can get more into the nitty-gritty of this method if you ask me later. But basically, it compares emergency department utilization of individuals who visited the food pantry in a specific quarter, let's say quarter 3 of 2016, with those who had yet to go to the food pantry in a later quarter. So our treatment is the first time the patient visited the food pantry. It doesn't mean that patients couldn't visit the food pantry later on as well. We use linear probability models to estimate changes in probability of future ED use across the entire post-intervention period, as well as for each individual quarter using event studies. And we also included propensity score weighting and controls based on age, gender, and race and ethnicity. And we incorporate a bunch of different sensitivity checks to make sure that these findings were robust. Interestingly, we wanted to see the intensity, whether the intensity of food pantry use had any impact on our findings. So people that visit the food pantry a lot more, maybe they had better outcomes or worse outcomes. So that was one of our sub-aims for this question. So here are our results. The food pantry sample, it was predominantly female, Black or African American, had a mean age of around 51, and averaged 13.4 total food pantry visits and 6.6 ED visits across the 4-year time span. And then looking at the differences between the lower intensity group and the higher intensity group, the higher intensity group was older, more likely to be female or Black or African American, and had lower mean A1C and blood pressure levels and ED visits compared to the lower intensity group. Okay, so this is probably the most interesting slide in the presentation, but this shows our main results. We can see here, prior to the intervention, there weren't, statistically significant differences between our treatment and comparison groups. However, after the fact, you can kind of see this downward sloping trajectory of decreases in ED utilization. So we found that there was an average of 7.3 percentage point decrease in subsequent emergency department utilization. And you can see, specific quarters where that effect might have been greater. That 7.3 is averaged across the entire post period. So this is just some more numbers, specifically in quarters 4, 7, and 8 after the first visit to the food pantry. There were 9.2 percentage point decreases, 10.7, 11.3. It sheds some credibility to the idea that there might be a longitudinal effect of food pantry use and patients having this compounding effect of going to the food pantry more and more over time. So when we look at the lower intensity group, we find similar findings. So before the intervention, on average, there were not significant differences between the groups. However, afterwards, we find more dramatic changes. So over the post period, there's an average of a 13.1 percentage point decrease in subsequent ED utilization. And like the main analysis, significant and greater effect sizes for specific quarters as well. One thing to note is that for the higher intensity group, we actually did not find any significant decreases in probability of ED utilization. And we'll talk about this more in the next slide about kind of some of those mechanisms as to why we think that. Kind of describing some of the key mechanisms behind our results. Food pantries likely improved food security for patients, provided patients with sort of non-health benefits, which then could have impacted their ED utilization. For instance, receiving food through the food pantry might have offset other household costs and mitigated other cost-related barriers to care for these patients. And the difference in food pantry intensity results might be attributed to the fact that the lower intensity group had higher baseline A1C levels, blood pressure levels, and rates of ED visits. So there might have been more opportunity for change in this group relative to the other group. So hospital-based food pantries might be one way to address some of the issues with the current approaches to addressing patients' unmet needs. So, many providers note that they're unable to immediately address the needs of their patients because of lack of funding or resources or partnerships with CBOs. Additionally, during the COVID-19 pandemic, there were really long wait times at community food pantries, and a lot of them didn't have enough food for patients. Thinking broader, for policy implications. So some states like Massachusetts and Oregon have begun to receive $11, $15 to use Medicaid funds to pay for food programs. So efforts like these could be explored as potential distribution mechanisms for distributing medically tailored meals or other nutrition-based services within a clinical setting. So these are some of our limitations. Obviously, the big one is we can't interpret these results as causal. We do a number of things to limit potential concerns for endogeneity. However, there could be other things that coincide exactly with the first food pantry visit that could have affected their ED utilization. Like other food pantries in the community or other BMC interventions or safety net programs. So we interpret these results as associative. And our study focused on one major health system, which limits generalizability. And this was a specifically quantitative project. We weren't able to qualitatively assess what specific elements of the food pantry program that could have facilitated lower ED utilization after they sought assistance. So in conclusion, co-locating food pantries and health systems that screen for unmet basic needs like food insecurity could be a key mechanism to reduce avoidable ED utilization among patients with diabetes. So thank you.